Welcome to Pulse&Pressors, where critical care gets crystal clear. In this module, we review Nicardipine, a dihydropyridine calcium channel blocker used for rapid, titratable blood pressure control in the ICU and perioperative settings. Nicardipine selectively inhibits L-type calcium channels in vascular smooth muscle. This decreases arteriolar tone and systemic vascular resistance, resulting in afterload reduction. It has negligible effect on myocardial conduction or contractility, making it a pure arterial vasodilator. Nicardipine lowers systemic vascular resistance and mean arterial pressure with predictable control. Mild reflex tachycardia can occur due to baroreceptor activation, but overall cardiac output is maintained. Intravenous Nicardipine begins to act within 5 to 15 minutes, with peak effect at about 30 to 45 minutes. Its short half-life allows tight titration, while hepatic metabolism ensures rapid reversibility once discontinued. Nicardipine is indicated in hypertensive emergencies and perioperative hypertension when controlled. Steady BP reduction is required. It is also useful in neurocritical and obstetric settings where preservation of organ perfusion is critical. In neurologic emergencies, Nicardipine provides gradual blood pressure reduction without elevating intracranial pressure. It maintains cerebral autoregulation, making it ideal for intracerebral hemorrhage, subarachnoid hemorrhage, and ischemic stroke management. In aortic dissection, Nicardipine must be paired with Beta-Blockade to control heart rate and shear stress. In post-cardiac or vascular surgery, it reduces afterload and maintains graft or suture integrity without compromising perfusion. Nicardipine is an effective antihypertensive in pregnancy-related hypertensive emergencies. It offers reliable control of blood pressure while maintaining uteroplacental flow and is considered a safe second-line option after labetalol or hydralazine. Avoid Nicardipine in fixed outflow obstruction, acute decompensated heart failure, or severe hepatic dysfunction. These conditions increase the risk of hypotension or delayed clearance. Use continuous arterial blood pressure monitoring during infusion. Evaluate for reflex tachycardia, monitor end-organ perfusion, and taper slowly to prevent rebound hypertension. Begin at 5 mg per hour and titrate upward in 2.5 mg increments every 5 to 15 minutes until target blood pressure is reached. Once stable, reduce to 3 mg per hour for maintenance. Avoid incompatible solutions and ensure dedicated IV access. Nicardipine-induced vasodilation can cause significant hypotension in hypovolemic patients. Optimize preload with fluids before increasing the infusion rate. It is generally tolerated in chronic low ejection fraction states, but contraindicated in acute decompensated heart failure due to risk of circulatory collapse. Nicardipine's predictable vasodilation, limited cardiac suppression, and short half-life allow for controlled, reversible hemodynamic management, particularly valuable in neuro and cardiovascular intensive care. Common adverse effects include hypotension, reflex tachycardia, and flushing. Local irritation may occur with peripheral infusion. Use a central line for extended therapy. Nicardipine is used across multiple ICU settings, from intracerebral hemorrhage and aortic dissection to postoperative hypertension and pregnancy-related crises. It is preferred for situations requiring precise, titratable BP control. Compared to other vasodilators, Nicardipine offers steady control without toxicity or unpredictable responses. Clofidipine provides faster kinetics, but Nicardipine remains more accessible and widely studied. Continuous hemodynamic monitoring is essential. Nicardipine should only be infused, not bolused. For tachycardic responses, add Beta-Blockade. Transition to long-acting oral agents once blood pressure stabilizes. Nicardipine is best suited for controlled reduction of arterial pressure, where rapid reversibility and stable perfusion are priorities. Avoid in situations of poor contractility or inadequate preload. This is Pulse&Pressors, reflecting on the marvels of the human body. Subscribe to learn more.